Well, I am thrilled and honored to be here. So a year after the Affordable Care Act was passed, Dr. Clay Christensen published The Innovator's Prescription, his incisive look at how we might, in fact, transform healthcare in this country. So those of you who have read it know that the book clocks in at about 500 pages, but there's this one sentence in it that, to me, captures in some ways the entire story of healthcare in this country. Dr. Christensen writes that there are more than 9,000 billing codes for individual procedures and units of care, but there's not a single billing code for helping patients stay well. And it's for that reason that I'm particularly grateful for the chance to be here today with kindred spirits who, as far as I can tell, very much share my conviction that if we are to truly not only envision but execute the healthcare system that we so urgently need, that is going to be foundationally rooted in leadership. So we each, I'm sure, have our own story for why we're in the room today. For me, this story begins 17 years ago as a freshman in college with this kind of notion that I was meant to be a lawyer when I grew up. And I signed up for an internship in the housing unit at Greater Boston Legal Services to test this theory. Showed up the first day on the job, totally prepared to make photocopies and coffee and all the things you're qualified to do when you're 17 years old. But instead was assigned to this deeply inspiring, righteous lawyer named Jeff Purcell, who thrust me onto the front lines from the very first day. And over the course of 9 months, I had the privilege of having dozens of conversations with low-income families in Boston who would come in presenting with housing issues because we were a housing unit, but whenever you scratch the surface, there was always an underlying health issue. My very first client, I'll never forget, came in. He was about to be evicted because he hadn't paid his rent, but of course he hadn't paid his rent because he was paying for his HIV medication and couldn't afford both. Or we would have these moms who would come in and, her daughter has asthma, but wakes up covered in cockroaches every single morning. And actually, one of our strategies, our litigation strategies, was to send me into the homes of these families and collect the cockroaches in these large glass bottles and then hot glue gun them to poster board, which we would then bring to court and inevitably win every case, mostly because the judge just did not want us in his courtroom, which I have to say was far more effective than any strategy I later learned in law school. But, over the course of the 9 months, I grew frustrated with feeling like we were intervening so far downstream in the lives of these families. By the time they came to us, literally their belongings would be on the street in front of their homes, and it just felt like there had to be a better way. So at the end of my freshman year of college, I read this article about the work that Dr. Barry Zuckerman was doing as chair of pediatrics of what was then Boston City Hospital, now Boston Medical Center. And Barry's first hire as chair was a legal services attorney to represent his patients, which I, of course, thought was totally genius. And with Dr. Zuckerman's blessing, I ended up spending about 6 months of my sophomore year kind of just wandering the halls of this completely beautiful but chaotic public hospital, and basically just asking physicians and nurses and other folks, if you had unlimited resources, what's the one thing you would give your patients? And I kept hearing the same story again and again, which is a story we've heard hundreds, if not thousands of times since then. They would say, every day we have patients who come into the clinic and the kid has an ear infection and I prescribe antibiotics, but the real issue is that there's no food at home. The real issue is that this family is living in a car, and I don't ask about those issues because there's nothing I can do. I have 13 minutes with each patient. Patients are piling up in the clinic waiting room. I wasn't trained to do this in med school, and we just don't have any capacity to help us with this. And I have to say, since then, I've had hundreds of conversations with physicians across the country who have said to me, literally, when it comes to patients' basic resource needs, we practice a don't ask, don't tell policy. They say, I can't ask my patients if they're running out of food at the end of the month, because what if the answer were yes? What would I do? And that's fair. The solutions are painfully thin. So even today, in that same clinic at Boston Medical Center, there are 2 social workers for 24,000 pediatric patients, which is pretty typical of the clinics where Health Leads works. We recently surveyed physicians at Bellevue Hospital in New York who reported that they spend on average 9.2 minutes of every 15-minute doctor's visit addressing their patients' social needs. One physician confessed that she spent on average of 45 minutes of every 15-minute visit on her patients' social needs, which, you at least have to appreciate her honesty. And this challenge is totally endemic. So Robert Johnson Foundation did a survey of 1,000 pediatricians and primary care physicians in 2011. 85% of the physicians surveyed said that addressing patients' social needs was as critical as addressing their clinical needs, but the same percentage said that they didn't feel confident in their capacity to do that. And 75% of them said that they felt that the healthcare system should pay to make these critical resource connections when they were necessary for the health of the patient. Art Gianelli, the CEO of Nassau University Medical Center, one of Health Lead's partner institutions, said to me this summer, I can pull every single clinical lever at my disposal, and I will never, ever deliver the results that CMS wants unless I have some way to reach beyond the walls of my institution into the lives of these patients. So Health Leads was born of this reality. In the clinics where we operate, physicians, nurses, and other healthcare providers can prescribe basic resources, safe housing, healthy food, exercise programs for their patients the same way they prescribe medication. Patients then take those prescriptions to Health Lead's desk in the clinic waiting room, where we have a well-trained core of college student advocates who work side by side with the patients to connect them to the existing landscape of community resources. We started in 1996 in the waiting room at BMC, totally lemonade stand style with a construction paper sign and a card table pulled out of a closet. But from the very first moment, we were completely swamped with patients who were so relieved to be able to speak at last, honestly, about the realities of their lives, and with doctors eager at last to be able to have those conversations with their patients. This year, our core of about 1,000 college student advocates connected about 11,500 patients and their families with the basic resources they need through 23 clinics in 6 cities. These are pediatric outpatient clinics, newborn nurseries, OB/GYN clinics, adult internal medicine clinics, and community health centers, all with significant Medicaid patient populations. But the key thing is that this is actually only half the story. As much as Health Leads is invested in changing the way that care is practiced now, we are also working to build the next generation of physician and other healthcare leaders who will transform healthcare in the future. Competitively recruited, we usually have between 3 and 10 applications for every slot, intensively trained and supervised by our team of full-time MSWs and seasoned case managers. Our cumulative 8,000 Health Leads advocates and the alumni they've become are healthcare's troublemakers. I was told that the polite term is disruptive innovators. They are instigating changes to their med school curricula. They are leading, not surprisingly, the primary care transformation efforts at their institutions, and they are delivering frontline health care to some of the most underserved populations in this country and across the globe. Each of these thousands of Health Leads alums will change healthcare differently, but they will all go on to reject the status quo. Rebecca Howe, a Health Leads alum applying to med school now, says, Health Leads has shown me the power of prevention. It's my goal to become a primary care physician and to incorporate Health Leads' comprehensive view of health into my daily practice. I've learned how language barriers and disjointed care can keep patients from accessing basic resources, but I've also learned that perseverance and compassion are invaluable. Health Leads inspires me to always keep the patient at the center. Patient-centered care. It's a goal so obvious, it's almost embarrassing that we have to state it as an aspiration. And yet, as you all well know, probably better than most, this stuff is really complicated. Author and Harvard surgeon Atul Gawande has this great line in one of his recent New Yorker pieces where he says, in medicine, good ideas still take an appallingly long time to trickle down. And I think that's our question today. How do we ensure that our good ideas, as Gawande calls them, become real, lived, and part of our everyday? So based on Health Lead's day in and day out work with hundreds of frontline clinicians and systems leaders at our partner institutions across the country, we've learned that there's at least two key drivers to make the notion of patient-centered care real. One is a more honest understanding of who our patients really are, and the other, not surprisingly, is the healthcare leadership necessary to deliver the right care for those patients. So first, an understanding of who our patients are. 3 weeks ago, Health Leads launched in 2 clinics at Mass General Hospital. These are your totally typical academic medical center adult internal medicine clinics staffed by both seasoned attendings and totally green residents, both of whom are completely overwhelmed by a growing number of patients and the simultaneous imperative around primary care transformation. Together, the clinics serve about 50,000 patients, 10,000 of which receive care through Medicaid. So to date, and by their own account, the clinicians at those clinics at MGH have officially, to this point, implemented a don't ask, don't tell policy on patients' social needs, and totally understandably so. We did a few weeks ago a baseline survey of the residents in the clinic, 91% of whom reported that they didn't feel equipped to address their patients' social needs. There's a cost, though, right, to averting our eyes from the realities of patients' lives. And that's a cost to both patients and it's a cost to the healthcare system. While only 20% of the patients in those clinics receive care through Medicaid, when MGH and Health Lead started to partner in systematically screening patients for unmet resource needs, we found, even by our own standards, that a shocking 59% of patients in those clinics cited one acute unmet resource need. So for example, they're telling us that they have their diabetes meds but can't refrigerate them because they haven't had electricity at home for 6 weeks. They can't afford to heat their homes to beat back the cold air that triggers their asthma every night. The day that Health Leads launched at MGH, our very first patient showed up at the clinic 30 minutes before it even opened. She sat patiently in the waiting room with a suitcase full of her possessions. And when our team began talking to her, she said, "All I want is a job. Everything else," she said, "a home, healthy food to manage my diabetes, it all depends on my getting a job." She'd been coming to this same clinic at MGH since 2006. Each of the 4 doctors she had met with over that time had told her that they knew she needed a job. She had told them the same, but they had never done anything about it. She said to us, "But this doctor, this time, after I told him what I needed, he sent me to you." She'd been waiting, not just that morning, for about 8 years. Health Leads referred her to an employment program. She's extremely motivated and has already enrolled and begun an active job search. She was totally ready. She just needed a healthcare system that wasn't just invested in whether she was managing her diabetes, but was invested in whether she could manage her diabetes. As Health Leads has worked to bridge tens of thousands of patients from the doctor's office to the community resources they need to be healthy, we've been really intentional about not just layering more stuff on. You guys are totally swamped as it is. Instead, we work side by side with the exceptional leadership of our partner institutions to systematically identify core elements of care delivery that we can appropriate intentionally and repurpose them to address patients' resource needs. We began with the prescription pad and asked not do what patients need to get healthy, so antibiotics, controller meds, insulin, but what do they need to be healthy? And how do we use the prescription for that thing? So thanks to the leadership of Dr. Barry Solomon, who's the medical director at the Harriet Lane Clinic at Johns Hopkins, now every time a pediatric patient comes into the primary care clinic there, they're asked a few simple questions. Are you worried about running out of food at the end of the month? Are you worried about paying your utilities bills? So when the doctor begins the visit, she knows blood pressure, height and weight, is there actually food at home? And she can do something about it. The physicians can prescribe these basic resources and make a referral to Health Leads like any other subspecialty referral. And our advocates, in turn, provide real-time updates to the clinic team via the EMR, enabling a much more refined set of clinical decisions. What's more, this spring, when Hopkins launched its new EMR, it's going with Epic, it did so with resource screening built in, not just at Harriet Lane, but throughout the entire pediatric hospital. There was no fancy IT build, no weird coding that happened, just a prescient decision by the leadership of that institution that it was time to start asking patients a different set of questions. And in one fell swoop, they turned their EMR from this static diagnostic and treatment repository to a live health promotion tool. And that's the kind of leadership that we need if we're going to really change healthcare. At the same time, HealthLeads arms our advocates with a killer technology platform. So when they enter in patients' demographic information and unmet resource needs, the platform automatically populates the community resources, let's say within a third of a mile of mom's home, that are open after 8 p.m. with a Spanish speaker on staff. So she has that information right there at the moment. And when the doctor says, your daughter's at risk of becoming obese, she should eat healthy and exercise more, right there we can connect them to healthy food, the scholarship program at the local YMCA for the exercise program, and income assistance so they can actually afford healthier food. But knowing and even tackling the realities of patients' lives isn't just about patient care, it's about population health. So how can you possibly understand what it's going to take to move the needle, in your patient population with respect to obesity or diabetes if you don't know that 40% of the patients in your clinic are running out of food at the end of each month? Part of what HealthLeads can do through this same tech platform is actually generate in real time precise information about the distribution and prevalence of unmet resource needs among the patient population, arming the leadership of those institutions with the kind of information they need to really understand the type and cost of care that will be required to deliver quality outcomes. Which brings me to the second driver to make real patient-centered care. It's the recognition that we need a new kind of leadership, the stuff we've been talking about all day, not just to manage the kind of seismic shifts in the structure and economics of healthcare, but to be able to deliver a healthcare that is accountable to the realities of patients' lives. So NCHL's validated health leadership competency model, which we at HealthLeads love, elegantly and usefully frames 3 prongs: people, execution, and transformation. And HealthLeads' experience on the ground vigorously affirms all 3. The MGH clinics converted from don't ask, don't tell to routinized screening of patients' resource needs in the matter of weeks because of key institutional leaders, including one, Dr. Alika Ray, MGH's Associate Program Director for Ambulatory Training, who swept aside the chronic obstacles that clog the pathway to systems change in healthcare, especially for vulnerable patient populations. And I know you all know this refrain well. Too many competing priorities, poverty is really messy, we'll deal with this later, or it's not my problem to deal with at all. So Dr. Ray may be just 3 years out of residency, but what was so striking to us in this process was that she was unafraid to ask the tough questions, totally unwilling to take no for an answer, and unhesitating in tackling the realities of her patients' lives. For her, addressing patients' social needs isn't a project, it's an imperative. And it's not surprising because she turns out to be a graduate of HealthLeads. And she's been at this work of addressing these issues with patients since her freshman year of college 14 years ago. And she's not alone. So 76% of HealthLeads alums who we recently surveyed work in healthcare. Of those, 54% work with underserved patient populations. 40% of our physician alumni are in primary care, compared to about 16% of graduating med students. Our advocates and alumni literally reflect the new face of healthcare. 56% of this year's HealthLeads advocates are students of color, 21% receive significant financial aid through Pell Grants, and 63% of them are fluent in Mandarin, Hindi, Vietnamese, Creole, and other languages. But beyond all this, we find that our alumni are impatient with, or even intolerant of, the traditional boundaries of clinical care. The notion that they're supposed to prescribe a nebulizer for a patient with asthma, but ignore whether or not there's electricity at home to use it. And this flows not from an academic experience with the quote-unquote social determinants of health, but from their front row seats, engaging with patient after patient, year after year, in making excruciating trade-offs between what it takes to deliver health for themselves and their families and to provide for their basic needs. Trade-offs, I will say, that not only millions of Americans currently face, but that as 21 million more Americans enter the system will only further define the reality of healthcare. HealthLeads alum Mia Lozada, who's actually now a medical officer with the Indian Health Service in Gallup, New Mexico, when she was a med student at University of Chicago, said, when my classmates write a prescription, they think their work is done. When I write a prescription, I think to myself, can the family read the prescription? Do they have transportation to the pharmacy? Do they have insurance to fill the prescription? And do they have food to take with it? Those are not questions, she said, I learned in med school. And for many of our alumni, these trade-offs are personal. HealthLeads alum Zoe Chavez grew up in Washington Heights, New York, and she tells this vivid story of being 5 years old and at her well-child visit, and her own well-child visit, and her pediatrician discovering that she and her mom were uninsured and sleeping on a friend's couch. And a decade later, when Zoe got into college but couldn't afford to go, it was her pediatrician who found her the scholarship to let her go to Brown University. And she, of course, tells her own story best.
My pediatrician really kept an eye on how I was developing as a person. I think we always spent maybe half of the checkup talking about my health. He knew that I was from a low-income background, and he also thought that I was smart. He believed in me. I attended a HealthLeads info session at the end of my freshman year, and I was hooked right away. I remember I finished my application that night. I listened to the advocates who were talking about the experiences that they'd had with families, and I still remember the stories that they told. I realized that model of connecting people to resources in their healthcare setting was what had enabled me to thrive as a child. I really didn't understand that that's what my doctor was doing. I thought he was just being nice. But I understood that it was something we could do strategically to help families out of poverty and to help families maintain health. One of the things that I've noticed here at the hospital is that ultimately all doctors want to be just like my pediatrician. They all know that health doesn't just happen in their exam rooms. It happens where we live and where we work and where we go to school. And so I see HealthLeads as a really great way to enable doctors to start asking those tough questions about, where are you living? What are you eating? Is everything okay? Because there's an undergraduate workforce that can solve any issues that come up.
So General Omar Bradley, a renowned World War II field commander, wisely, if sort of dourly, observed that amateurs talk about strategy, professionals talk logistics. And I think this reflects kind of that perfect toggle that NCHL has framed around transformation and execution. And I would say, I think one of the critical leadership challenges ahead for all of us is that persistent calibration between our vision for our health system and our own healthcare institutions and the often super messy on-the-ground reality of caring for patients. And as much as we may strive to plot the strategy of the healthcare system or even, again, the future of our institutions, there's probably nothing more certain than the fact that it is completely uncertain what will happen to our healthcare system 10 years from now. But there's one piece that will assuredly remain constant, and that's the complexities of patients' lives. So our hypothesis is that at the end of the day, we will evaluate our healthcare leaders not on how quickly they led the assimilation of some new technology or even the extent to which they decreased costs, but how deeply they understood and how quickly they acted upon the realities of their patients' lives. Our belief is that together we can instill in both our current and our future healthcare leaders that patients' social needs aren't messy or expensive or tedious, but just as obvious as and important as any other vital sign. that care isn't actually patient-centered when we tell a patient to eat healthy, but we don't recognize the linguistic, bureaucratic, administrative, and transportation barriers they will almost inevitably face to make the doctor's advice real. And that population health doesn't just have to be a new buzzword or some fancy way to get paid, but might actually be the best and most logical way for care to be delivered. So this is just simply to say that our belief is that we act together now and pour our most deeply held convictions into creating that next generation healthcare leadership, that we can at last move from imagination to implementation and create a different kind of healthcare system for our patients, for our providers, and for all of us. Thank you.